Good afternoon, everyone, and thanks for joining in. I'm Dr. Kim Newell-Green, and as usual, I'll be the moderator for this virtual Grand Rounds, which is sponsored generously by California Health and Human Services and the California Medical Association. The Grand Rounds today is entitled Spotlight on COVID-19 Vaccines. Next slide, please. I'd like to invite you to see our disclosure slide and just remind you, next slide please, that CME is being provided. This is our agenda today. Next slide please. And in order to get CME, just remember to please fill out the survey that will be sent to you after the completion of the webinar. You'll attest to your attendance and then we can send you your certificates. Next slide please. Today, I'll keep the intro very brief because we have such an amazing powerhouse of women to educate us today. But it really has been an exciting month and a word salad of acronyms as the FDA, the CDC, and our own regional vaccine task force, which is the WSSSRG, though nobody calls it that but me. They have all met to make important decisions this month. Today, we're incredibly thrilled to have alongside Dr. Erica Pan, who's often with us, two incredible infectious disease doctors who are members of these important task forces. They're also researchers and clinicians and leaders in many parts of this. So let's just dive right in. These women have so much knowledge. So as we hear from them, please do submit the questions you may have using the question box on the control panel. It's located on the right-hand side of your screen. Our first presenter today will be Dr. Andy Shane. Dr. Shane is a pediatric infectious disease physician who has a passion for the prevention of infectious disease in children, both locally and globally. She was born in South Africa. She's done training at the University of Pennsylvania, Columbia University in New Orleans and the Bronx. Dr. Shane was also an epidemic service intelligence officer at the Centers for Disease Control and Prevention in Atlanta and completed her pediatric infectious disease fellowship at University of California, San Francisco, where she trained me. She currently divides her time serving as the division chief of the Division of Pediatric Infectious Disease at Emory. Her responsibilities as the Marcus Professor of Hospital Epidemiology and Infection Prevention for the Children's Healthcare of Atlanta system. She serves as the acting editor-in-chief of the Journal of Pediatric Infectious Disease Society, another JPIDS, that's the word salad there, caring for patients. She also performs clinical research and teaches and mentors. She's been on an FDA advisory committee and has done research on both the Pfizer and Moderna vaccines in kids. And so I can't think of many people more prepared to guide us and our understanding of this exciting moment in vaccines. Leave it to you, Andy. Thank you.
Thank you so much, Kim, and thank you to the organizers. And I'm so delighted to be here with, just have to mention, Erica actually trained me during my fellowship at UCSF. So wonderful opportunity and thank you. So I thought in the next few minutes I would talk a little bit about the why and how of pediatric COVID-19 vaccination. If I could have the next slide, please. So I just wanted to start out with a couple of disclosures. I am a voting member of the FDA VRBPAC, which is another word salad. The vaccine-related biologic and biologic products advisory committee, which actually was the committee that reviewed the data for FDA authorization of COVID-19 vaccines, both in adults and children. But I have not participated in any discussions or meetings related specifically to COVID-19 vaccinations. I also have some other disclosures about funds that my employer has received and also some travel and lodging stipends that I've received. Next slide, please. So I thought I would start out a little bit with the why of pediatric vaccines, and we've all been living through this, so this is not new data, but I think it is very important to look at it graphically. And what you see here, this is a slide that was put together by the Children's Hospital Association in collaboration with the American Academy of Pediatrics. And periodically, these two organizations have been compiling data related to COVID-19 nationally, and also have received data from the individual states about COVID-19 epidemiology in children. And this slide, what you can see is on the y-axis, the number of cases that are added by week, and on the x-axis, the weeks and the end of the week, starting in actually in April of 2020 when this data was initially compiled. The light blue are the number of adult cases, and the darker blue are the number of child cases. And we see the two peaks paralleling very nicely in children and adults, as well as the higher peak that we most recently all saw during the summer in the United States. And while this does emphasize that adults have been more adversely affected in terms of number of cases, as we all know, and I will discuss, the impact on children has been tremendous as well. Next slide, please. And this is just another slide that also demonstrates some of the epi that we saw between April 2020 and October of 2021. And this is just the number of child cases only that were added per week. And once again, you can see the two peaks, with a higher peak in the summer, and notably higher than what we saw in the approximately a year ago in December and January of 2020. Next slide, please. And then this is another slide from that same presentation with a map of the United States, each state represented graphically. The darker colors represent higher number of pediatric COVID-19 cases in thousands, and you can see that both California and Georgia, where I am located, are darker blue, indicating that we have had a larger number of cases. On the right-hand side of the slide, as you're facing it, you can see the percent increase by week, and this is the last data that was available, the last 2 weeks in October of 2021. And you can see that there are higher number of cases actually in Vermont and lower number of cases for that 2-week period in California and also in Georgia. And it's been very interesting to track total number of cases and then cases week by week that these organizations have been compiling. Next slide, please. So that's the complete epidemiology, at least of number of cases of COVID-19 in children. And what I also want to discuss very briefly is MIS-C, also known as Multisystem Inflammatory Syndrome in children. And this is a post-infectious phenomenon that occurs after an acute COVID-19 infection. Some children have actually had symptomatic infections, and some have had asymptomatic or unrecognized acute COVID-19 infections. The symptoms of MIS-C, which are multi-system, consisting of fever, and then also a number of other symptoms, including cardiac, gastrointestinal, some neurologic, as well as dermatologic and sometimes mucosal symptoms, then occur over a period of time. Most of these MIS-C, children with MIS-C, present between 3 to 4 weeks after their initial infection, when we know the date of the initial infection. And actually what we saw during the second wave with Delta was that the onset from acute infection to the time of actual MIS-C seemed to be prolonged, at least locally here in Georgia, and that was also described in other states around the country. And we also had sort of a later onset of MIS-C compared with the December-January 2020 peak that was previously seen. So while MIS-C is very rare, there have been over 5,000 cases that have met the surveillance definition according to CDC, and approximately 50 deaths. And so certainly this is something that is extremely important to be aware of. And one way of preventing MIS-C is by preventing an initial acute COVID-19 infection, another justification for immunization. I also wanted to point out in the map on the lower left of the slide that both California and Georgia, once again, are darker in color, indicating higher number of cases per population. And that is something that corresponds with the number of acute cases. On the right-hand lower part of the slide, as you're facing it, you can also see MIS-C cases that have been divided by age group. And the largest peak actually is in children 5 to 11 years of age, which as of this last compilation of data at the end of October by CDC, comprised about 40% of the total cases of pediatric MIS-C. There's also an adult equivalent called MIS-A, and that has also been well described in adults with the multisystem inflammatory sequelae that occur after an acute COVID infection in adults. Next slide, please. So in addition to thinking about the acute COVID and MIS-C, I like to think about the COVID-19 impact, both the clinical impact and the non-clinical impact. And those of us who have taken care of children and or have taken care of families who have had children, we know that there's been a tremendous interruption of routine health care, decrease in immunization uptake of routine childhood immunizations, up to 40% decline has been estimated in some surveys. We've all seen an increase in the number of children with depression, anxiety, and mental health sequelae. In hospitals, a number of what we have traditionally termed elective procedures have been canceled due to concerns or fears about COVID-19, both in children and in healthcare clinicians. And in some cases, there's been a tremendous focus on COVID-19. Obviously, we have a pandemic, but that has also skewed some of our diagnostic acumen. And many people have really been very focused on COVID-19 and may not have thought about non-COVID-19 diagnoses, which are, of course, very important to think about as well. Then the non-clinical impact, changes in routine, stress and isolation, disruptions in learning. The impact on school and education has been tremendous, not just the actual education itself, but access to school-based services where children often receive nutrition, speech and occupational therapy, mental health services. Our medically complex children who are so dependent on therapies and services have been adversely impacted. Many children have missed significant life events, birthdays of family members, vacations, tremendous increase in housing and food insecurity, and notable increases in accidental and non-accidental trauma. And all these have been a result of the pandemic, as well as increasing acute COVID-19 infections. Next slide, please. So what can we do and how can we address some of these challenges? So when we think about vaccination, obviously, ideally, every child has a medical home, and that's what we really aspire to. But in some situations, especially our medically complex children, as well as children who don't have a medical home, who access clinical care in our hospital urgent care systems, we have to think about these locations as opportunities for vaccination and opportunities to educate children and their families about vaccination. And many of us have been providing employee vaccinations in hospitals and healthcare settings, thinking about ways to combine employee vaccination and also vaccination of adults and hospitalized, for example, parents of hospitalized children who may not otherwise have access to a vaccine facility or being able to be vaccinated because they're attending to their child in the hospital. Next slide, please. So I just wanted to spend a few minutes talking about the how of the pediatric COVID-19 vaccine, sort of the life cycle. I will start this out and then I'll turn it over to Grace to continue with discussion about the ACIP. So a vaccine candidate is identified. That vaccine candidate is then evaluated in clinical trials, and in children, we initially were looking at children 12 to 17 with the Pfizer vaccine, and then Moderna also have been, clinical trials have been ongoing with the Moderna product for children. So Moderna and Pfizer trials have been going on simultaneously. And those clinical trials have been done in a very structured and organized way with enrollment, the idea being to engage centers around the country so that we can have regional representation, and a special emphasis on trying to have participation in clinical trials by children who are adversely affected by COVID-19 from our Black African and also Hispanic children. Next slide, please. But performing clinical trials in children is challenging. There are unique ethical and clinical concerns. We also have to balance the risks of research with the need for safe and validated therapies. Children are different, especially at different ages, and so we have to account for developmental and physiological differences in children of different ages. And the way many of these trials are done, and especially with the vaccines, has been an age de-escalation for dosing. So trying to balance the efficacy and adverse effects, starting with older children and then progressively moving down to younger age children. Clinical trials in children require informed consent and then assent from a child who's age appropriate and developmentally appropriate. So we've had lots of discussions about how we can optimize clinical trials in children and how we can overcome some of the challenges of the traditional ways that we conduct trials, and engaging children in clinical trials from the outset has been looked at and evaluated. And I think if it's something that we can think about as a lesson learned, this is one aspect. It is wonderful that we now have an authorized vaccination for children aged 5 to 11, but it would have been wonderful if we could have had it a little bit sooner. Next slide, please. So I just wanted to quickly discuss a couple of operational issues about FDA approval. The FDA provides scientific and regulatory advice to vaccine developers. And throughout the clinical trial, throughout the whole process, the FDA has been actively engaged in working with both Pfizer, Moderna, Johnson & Johnson, and other vaccine manufacturers of vaccine candidates to try to help them understand what data is needed for authorization. And then these vaccines are authorized under something called EUA, more word salad, emergency use authorization, which is a mechanism to facilitate the availability and use of medical countermeasures during public health emergencies. And an EUA is issued when there's no adequate, approved, or available alternative. And it's important, I think, to emphasize that these clinical trials that contributed data to the EUA process are very rigorous, and they are conducted just the same as a regular clinical trial would be. The issue is that they're conducted, there are more places that are conducting the trials, and speed really is of the essence, but speed while still paying attention to all of the regulatory requirements. Next slide, please. So it's really important that the FDA has adequate manufacturing information to ensure quality and consistency of the product. The known and potential benefits must outweigh the known and potential risks. It's very important that the phase 3 participants have at least 2 months of follow-up after the last dose, so at least half of the phase 3 participants, and more than 3,000 participants have to be followed for more than 1 month before the FDA will review data. Then there's a public meeting of the FDA VRBPAC to review the safety and efficacy data. And in parallel with that FDA VRBPAC meeting, the FDA staff, scientists, consider the recommendation of the VRBPAC and also provide their own input and their own review. Next slide, please. And so follow-up monitoring is really a key component of the emergency use authorization. And I think that this is really a key point that we can emphasize when we're talking to families. There's active follow-up for safety events, including hospitalization, deaths, other serious or clinically significant events. And it's the joint responsibility of both the FDA and the CDC, along with healthcare partners, to contribute data and information in this active follow-up and monitoring. Thank you. I think that ends my slides. Sorry, I have key points. COVID-19 vaccines are the foundation of mitigation measures against SARS-CoV-2. And also just emphasizing, although brought to evaluation rapidly, COVID-19 vaccine candidates underwent rigorous evaluation and review in clinical trials. The benefits and risks of COVID-19 vaccines for children were carefully considered by the FDA and by the External Advisory Committee, the VRBPAC. And we know that children have been adversely impacted by COVID-19 and should be a priority for clinical trial participation and inclusion while considering the challenges. Thank you.
Thanks so much, Andy, and we look forward to talking to you later with our Q&A. And now it's my pleasure to welcome back Dr. Grace Lee. Dr. Lee spoke to us earlier this year. Dr. Lee trained at Penn and at Boston Children's Hospital, and she's now a professor of pediatrics at Stanford University School of Medicine, and she's the Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health. Grace is truly a wonderful leader and researcher. I will not be able to read her whole bio, but she previously served as the principal investigator in numerous CDC, FDA, and AHRQ grants. She's a member of the Institute of Medicine committees to review priorities in the National Vaccine Plan, the ethical and scientific issues in studying the safety of approved drugs. She also holds leadership positions in many other organizations in her field. She is currently the chair of the U.S. Advisory Committee on Immunization Practices, that's the ACIP, that recommends, this organization sets recommendations for the use of vaccines in the U.S. population, and that has included COVID-19 vaccines. So again, an amazing opportunity to hear straight from the experts. Thanks, Grace.
Thank you so much for having me. We can move to the next slide. I have no financial disclosures. My only disclosure is I am chair of the ACIP, but I will state that the views are my own. And I thought it would be interesting, since many of you have seen the data that have been presented publicly, just to perhaps take a step back and think through some of the decision-making pieces of this and what is happening sort of as a member of ACIP. Next slide. So as Dr. Shane mentioned, this is sort of the life cycle of vaccines going from development to implementation. We start out with the vaccine development and testing in phase 1, 2, and 3 clinical trials. Those data typically are submitted by companies to the FDA for either a biologics licensing application or a BLA, or emergency use authorization in the case of COVID-19 vaccines, so an EUA. The VRBPAC, which is the Vaccines and Related Biologic Products Advisory Committee that Dr. Shane and many of our colleagues sit on, is a federal advisory committee that advises the commissioner of the FDA on the regulatory use of vaccines in the US population. After VRBPAC meets and provides their scientific guidance to the commissioner of the FDA will decide whether or not to approve or authorize a vaccine for use in the U.S. population. And the other thing I'll just note about the FDA process is that it's a really rigorous process where the FDA scientists are actually not only reviewing the data, but actually reanalyzing the data at the individual level to make sure that their conclusions agree with those of the manufacturer or the sponsor. And so I think that that's an incredibly robust process that's become very important, particularly in the era of COVID vaccines, but with all approved medical products. After FDA approves or licenses a vaccine for use, then it typically comes to the Advisory Committee on Immunization Practices, which is ACIP. This is also a federal advisory committee, and our role is to advise the director of the CDC on recommendations for use of the vaccine in the US civilian population. What's different, I think, about these federal advisory committees, and I think many individuals now have at least heard mostly of these committees, that because they are federal advisory committees, I think they have a unique role in that these are independent scientific experts. None of us are, employed by these agencies. We provide advice and guidance to the heads of those agencies, and all of our meetings are done in public. And to me, that has been a really important part of the process that we hope helps to build trust, transparency, and a greater understanding of the rationale behind decision-making for each of the components that come to these committees. That public process includes public comment, and we definitely hear a lot as committee members and as the committee itself from key individuals and societies and organizations, all who have views about the use of vaccines or the regulatory approval of these vaccines. Next slide. ACIP, and I put this up here to share the types of expertise and perspectives that are included. So as you would anticipate, pediatrics, internal medicine, family medicine, OB, geriatrics, ID, nursing, immunology, vaccine research and policy. We also typically have economics and cost effectiveness expertise, in addition to safety expertise. And public health expertise as well. There is one member of the committee that is a consumer representative, and I think that has also been a really important part of our committee to make sure that the consumer voice is really represented and heard in these committee meetings, and that we are always thinking about these recommendations as something that we're doing, for patients and families, taking that perspective, I think for me has been a really important process. And I also would encourage, if anyone is interested, to consider applying for ACIP membership. Every year there's opportunities to apply for ACIP membership, and it's been a really wonderful experience to be a part of this committee. Next slide. Oh, and there are also 8 ex officio members, so our federal agencies such as CDC, FDA, DOD, CMS, OIDP, NIH, and I'm sure Indian Health Services and others, and then 33 liaison members. And actually those liaison members, so what you'll see here is the committees in the inner table here on the left, and on the outer table when we were meeting in person, those are all the liaison representatives to ACIP. And actually that the liaison representatives have a really important voice and perspective that they share with the committee during our deliberations. And for example, many of the individuals around those table represent provider organizations or immunization registries or, hospitals and hospital epi. I mean, all of these perspectives are incredibly important as we're thinking about not only these recommendations, but how implementation of these recommendations might flow, and would that be helpful or influence the way we think about these recommendations. And oftentimes it really does have a significant impact. Next slide. And then if you could hit the slide again. I didn't mean for this to be animated. The ACIP considers recommendations on use of vaccines in the US population, as I had mentioned, and we rely on what's called a evidence to recommendations framework, or ETR framework, and we adopted this in 2018. In fact, we have been using GRADE, which is our way of reviewing the scientific data, understanding the benefit risk balance, as well as the certainty around those judgments, for over a decade, but I really appreciated being able to adopt this particular framework, which I'll walk you through briefly, as an important component of ensuring that we are transparent in our decision-making, that we are consistent in our implementation, and that it gives us a tool to communicate deliberations and judgments made during the formulation of these recommendations. And it is really important for us to reflect diverse viewpoints. So you might only hear that there's a vote of 14-0 for pediatrics, or I wouldn't say it was 9-8 for an amendment of a particular vote last week. But it's really important that we reflect and include the minority opinions or any dissenting views as a part of that process to reflect the scientific data that we have available and the uncertainty around that data. Next slide. And if you go to the ACIP website, I'll just say that you can see all the GRADE assessments that have been done, as well as the evidence to recommendations framework that is done for every single vaccine recommendation since 2018. These are the domains that are considered under the evidence to recommendations framework. I go through these not to review every single domain, but I wanted to just highlight a few that I think were really helpful to us. And I do want to emphasize that the committee includes 15 members, all with diverse viewpoints, values, and experiences that we bring to the table. And so being able to have the committee members reflect on all of these domains in a consistent manner, I think helps us understand how one ACI committee in 2 years ago might look at that same data and come to a different committee, for example, in a different country or in a different time point, but come to a different recommendation. And the reason often is not simply just benefit risk balance. There are a host of other considerations that influence decision-making, such as the domains listed here. So I'll just highlight a few of these that were relevant to us or have been relevant to us during the COVID-19 pandemic, and more recently around, for example, the booster decision. So public health burden and the dynamics of the pandemic have clearly played a role in our understanding of the potential benefits and the benefit-risk balance of vaccination. Benefits and risks, for us typically are done as vaccines are approved for use, and we usually rely on clinical trials. What's been different about the pandemic is the amount and the speed and the volume of data that we've had with regard to effectiveness and safety in the post-authorization world. We are continually updating and reviewing those data and the benefit-risk balance in the context of the dynamics of the pandemic. We have very much, considered both individual and population level benefit-risk balance. I would say that we have been very focused on making sure that the individual benefit-risk balance is justified for all of these vaccines under the COVID-19 EUA authorizations. And that's been a really important part for all of us, in addition to recognizing the population level benefits that are conferred by vaccination programs. The values and preferences of the population receiving the vaccines are always considered and are incredibly important. We also looked to our key stakeholders, such as those liaison organizations around the table, as one example. They are often our frontline vaccinators, and during a pandemic, we discussed the challenges of implementing recommendations such as risk-based criteria in mass vaccination clinics and how that might influence how we think about our recommendations. In this case, resource use, fortunately vaccines are provided free of charge, and so that has not been a major component relevant to our decision making, and clearly the economic and health impact has been tremendous. So we haven't done formal cost benefit analyses, but rather sort of informal ones. Equity is a domain that has been newly integrated and cemented into what I think is critical to the foundation of the evidence to recommendations framework. As has been evidenced by the impact of the COVID-19 pandemic that has not been clearly distributed equitably in any way. So we think about the impact of intervention on equity and also the impact of the recommendation type on equity. And I say that because we usually have two types of recommendations. One is we recommend, or the second is what's called shared clinical decision making. In the COVID-19 pandemic, that has gotten translated into we should get vaccinated or you may get vaccinated. And both of those things, I think, are influencing our judgments on how we think about the recommendation as individuals. In addition, equity clearly is linked to access issues, and then, of course, the values of the individuals being vaccinated. And then feasibility, of course, is always a consideration and always a discussion point. And we think about not that feasibility should necessarily drive the recommendation, but it certainly influences how we think about the recommendation and whether or not there are ways for our recommendation to minimize barriers to implementation as a component of our discussion and our decision-making process. So next slide. In terms of the booster story, I'll just give you sort of my own views on this. And again, many of you probably have seen the recommendations that have come out and have seen, maybe parts of the meeting. I kind of took away sort of 4 points from the booster story. Number one, the challenge of recommendations based on an EUA versus a BLA. So the ACIP can only consider use of vaccines authorized or approved by the FDA. Typically under full approval, which is through a BLA or this biologics licensing application, there is some flexibility in how ACIP can recommend use of vaccines and in how clinicians can use vaccines at the individual level when you're making decisions with your own patients. Meaning we can use them on label or we can use them off label. However, under an EUA, we are constrained by the specifics of the authorization under a public health emergency. And so what Dr. Shane was discussing around the way that FDA provides those EUA recommendations very much defines for us at ACIP what we can and cannot recommend. So that has been a challenge with the booster story, but also, I think reflects the fact that you have two independent scientific committees that are reviewing these data, and each with our own sort of perspectives and takes on it. Even though the roles of these committees are different in nature, clearly one can influence the other. Benefit risk balance, varying by age and gender. I'll also add time since vaccination and circulating variants clearly to the booster story. The systems in place to continuously monitor both efficacy and safety have helped us to better understand how individual characteristics can impact our benefit risk balance. So, clearly the story around benefits being greatest in older adult individuals and medically fragile individuals is evident in the rates of hospitalizations, severe disease, and death. In addition, we've seen actually, and I would say this has been very different for me in terms of vaccine safety in thinking about adverse events by gender and age group. The examples being the potential for myocarditis following mRNA vaccination in younger males, or the risk for TTS, albeit rare, following a J&J or Janssen vaccine in adult females. And so that to me has actually been different than the way we typically think about vaccine safety. We have so much information with 400+ million doses administered in the US that we are able to actually provide this level of detail and nuance. And I think we are also fortunate in the US in having multiple vaccine products available that allow us to provide that guidance to individual patients. And I think it often also reflects the challenges in decision making because everyone's individual circumstance can be quite different. The other component that I'd actually highlight in this is that the incremental benefit of a booster dose over a primary series is different than going from being unvaccinated to being fully vaccinated. So I think while the benefit risk balance has varied by age and gender and by sort of vaccine type, it also is attenuated to a certain extent or comes in closer balance around the booster dose discussion, which is why you see a should and a may recommendation, which I'll go over in a moment. The values really do differ. And I think this is like sort of, we bring our personal values to the table about preventing infection versus severe disease. I think there's pretty much near unanimity that everyone wants to prevent severe disease in those who are at risk for severe disease. We don't always know who's perfectly at risk for severe disease. So for example, 1/3 of children have no known risk factors and yet are hospitalized, but it does allow you to do some risk stratification. And others, I think, value preventing infection just as much as severe disease. And again, that might be our own values coming through, but in addition to individual values in terms of thinking about their own benefits and risks of vaccination. Individual population benefit risk balance are clearly linked in that the more individuals that are vaccinated, the population does better as a whole. And we can see that in our state level and county level data in highly vaccinated populations, for example, compared to lower vaccinated populations. And in addition, population level benefit risk balance and a focus on that can impact individuals, and particularly those who might be vulnerable and not respond to vaccines, those who are severely immunocompromised. But we do have to acknowledge that perhaps the benefits and risks are not evenly distributed across all individuals. And I think that has been the challenge with the booster story to date, and wanting to be transparent about those benefits and risks with all individuals who receive them. And finally, I'll just say that the recommendations can impact equity. So clearly, as central to all of our discussions has been the issue of the inequities in a disease burden, impact on the economic welfare of families, and also just in pediatric data we just saw last week that there are severe cases of hospitalization, MIS-C, and death that disproportionately affect children who are Black and Hispanic, as an example. And so that continues to plague us even though we are a year and a half into this pandemic. And although we can try and think about how we can optimize our recommendations to ensure we are addressing equity, it is also clear to me that equity is truly addressed on the front line. So implementation is far more influential in how well we can address equity, and far more so than our recommendations, but we hope that our recommendations will influence the ability to implement easily and reduce those inequities along the way. Next slide. So the booster recommendations are the following. So individuals should receive a booster shot at least 2 months after their J&J or Janssen vaccine, and they should receive a booster shot at least 6 months after their primary series with mRNA vaccines if you are 65 and older, resident in a long-term care setting, or 50 to 65 with underlying medical conditions, again with a focus on severe disease in those categories. And as discussed on the last slide, we talked about who may receive a booster shot at least 6 months after their primary series with mRNA vaccines. This is based on individual benefit risk balance and includes a broad population, actually, those 18 to 49 years with underlying medical conditions and 18 to 64 who are at increased risk due to occupational or institutional settings. And as you'll, as was, I think it was in the news today that, Pfizer is planning to seek authorization for boosters for anyone 18 and older, I think in a way to simplify the recommendation. But again, it doesn't take away the fact that we need to continue to educate individuals about their own individual benefits and risks of a booster dose. And I'd still say that the most important thing is to make sure individuals get fully vaccinated. Going from unvaccinated to vaccinated will make a much huger impact in their life overall and in our communities. Next slide. Pediatric vaccines, just a few comments. The burden of COVID-19, as Dr. Shane mentioned, is not just the impact on health, but it's the impact on educational outcomes, impact on family outcomes. The mitigation measures that we have in place, are not sustainable over many years. So school closures, obviously we want to avoid that if we can. And we've saw last week that there have been thousands of school closures as a consequence of COVID, or inconsistent implementation is my way of phrasing it, meaning that, we have some schools that have adopted masking and other areas of the country where masking is actually discouraged. And that actually, puts those individuals who are in the schools at risk. So clearly, COVID-19 vaccines, making that available to kids, that would be the most effective and reliable way we can offer protection to those kids, regardless of their surrounding circumstances. The other issue that keeps coming up is that COVID infection in children is often compared to adults, which to me implies there's a lower value of prevention in children. And although severe disease may be less common, many of us who are caring for these patients, have seen children die of COVID, have seen severe hospitalizations and ICU admissions due to COVID. And to those parents, the value of prevention is huge. So even though the numbers may be smaller, I personally think that we need to focus on the value of prevention in each population on its own and not compare it to, well, it's not as bad as adults, which is what I often hear. And then finally, inequities in infections, hospitalizations, and deaths remain substantial, and we need to continue to focus on our implementation efforts and our outreach efforts to address those inequities. Next slide. I'll go quickly on the last few slides, which is I was just asked to provide an overview of vaccine safety surveillance in the US. This is just to state that since the first dose went into the first arm, I believe it was December 12th of 2020, the federal agencies and their partners have been investigating and monitoring vaccine safety since day one. There are all of these systems that are in place that are being monitored actively by a federal collaboration that we have and through one of our ACIP committees called VAST. I'll just highlight the ones on the left. So VSafe, VAERS, and CISA are three systems that I continue to encourage clinicians and families and patients to engage in. So VSafe is direct to patients. Children can be enrolled through their parents' email address in VSafe so that we can have parents actually contributing to safety monitoring in the pediatric population. VAERS and CISA are always available, and they have been incredibly important for us to ensure that we have a good understanding of the risks and the benefit-risk balance. And for those who have challenging cases, I am very much encouraging many of the clinicians I talk to go to CISA to seek that individual consult. Next slide. VAST is a vaccine safety technical work group of the ACIP that I chaired for a while, and now Dr. Kip Talbot chairs. And we have had, this was a couple of meetings ago, so we have been meeting essentially weekly since the pandemic started and been reviewing all these data. What you see up top are all the ACIP votes, and what you see on the bottom are all the VAST assessments, either at ACIP meetings or through the website. The point being that every time a signal arises or there are any concerns that come through, those data are being presented publicly and for open deliberation by the full committee. And that, again, that is an important part of our process. And I can assure you that there are many eyes on the vaccine safety surveillance systems in the US. Next slide. And this goes on to the more recent decisions that we've had up top, as well as our continued commitment to ensuring that these data are presented in ACIP open meetings, or if we don't have a meeting on our website, but we've had enough meetings that we've been presenting in open meetings. Next slide. And then finally, I'll just highlight the importance of context. So when people ask me about safety, safety to me does not mean zero risk. Safety is really the balance of the benefits and the risks. And the trajectory of the pandemic has been difficult to predict. And I think that is part of the uncertainty that exists out there. I just highlight one particular paper that I really liked, which is out from Israel, where they actually compared the risk of any adverse events, either following vaccination in blue or following SARS-CoV-2 infection in the orange. And what you'll see here is, for example, the risk of acute kidney injury is quite high among those who are infected. And if you're vaccinated, it actually looks protective in this instance. And if you look across the way, you'll see, again, the story around myocarditis actually shown here that the risks following infection are higher than the risks following vaccination. But again, we need to be transparent and acknowledge what risks we do know about. Next slide. So my final points are that ACIP decision-making is a dynamic process. It is not fixed at one point in time, and we continually reevaluate our decisions based on new information. It has been challenging to explain uncertainty to the public and what that means. I think sometimes people want a certain answer, and I think part of that transparency is sharing what we know and what we don't know. And clearly, to this audience, providers are the trusted voice, I would say. And so engaging patients and families on the benefit-risk balance and their own personal values is really important to help with the should recommendation. And supporting individual decision-making is really an important role we play in those who may get vaccinated. And really appreciate the CMA for putting this session together, and my colleagues for also sharing this information. Thank you.
Thanks so much, Dr. Lee. It's really fascinating to see the ins and outs of that process, and I look forward to asking some specific questions. Now I'm going to invite on our regular presenter, Dr. Erica Pun, who is our state epidemiologist and also trained me at UCSF, since we're talking about that today. So welcome, Erica, and thank you.
Great, thank you. Such a pleasure to be on with so many pediatric colleagues and yes, Peds ID colleagues. And I really just want to also shout out to Grace specifically on her role in our Western State Scientific Safety Review Work Group, another alphabet soup, but always appreciate hearing kind of her perspective as she shared today, and just hearing where that background was really insightful as well, but always insightful and very objective, and just appreciate all that. Next slide. So I'm going to kind of step back and just give some California specific data, kind of where are we now, what are we looking at, a little bit of a deep dive into pediatric data, and more to come in the future. A quick update, a little off topic, but on our schools guidance, and then just a little bit more about where we are in California on boosters and the 5 to 11-year-old vaccine rollout. Next slide. So you all by now are used to seeing, this is kind of our epi curve, and on the lower left-hand corner, you can see the overall course of the pandemic, and then pulled out April till now of this year. And again, the blue line is cases, orange is hospitalizations, the red line is deaths, which are not to scale, and then the black line is the ICU. And as you can see here, so this is our the big peak there is the Delta surge of cases, and we had a nice decline until certainly a little bit of a bump recently. But many people may ask, well, we got through the Delta surge, we may just have to live with more cases, but I think even more concerning is what we're seeing here in this orange line trend, that the hospitalizations seem to be maybe creeping up again. And this obviously varies a lot by region. Next slide. And I'll touch more on the regional differences in a moment. This also just again with the focus on pediatrics and some of the new availability that we're excited about. Similar to some of the US data that Dr. Shane showed, we have about 24% or so of our cases now are in pediatric age groups. And it's also interesting to note here that we have seen, over time, as we've gotten vaccinations, we had seen some decreases in the elderly proportions, but maybe starting to creep up again, which, one could surmise, and paired with other data about waning immunity, that maybe there's some waning immunity there. And then also, as we've seen, when you do a pullout of this, which I didn't provide for you today, but when you do a pullout in the pediatric data as well, you can see that the 12 to 17-year-old cases actually decreased over the last half of this year, whereas the proportion, and as you can see here, of 5 to 11-year-old cases has increased between the last winter surge and now. So it's up to 10% of our cases are in that 5 to 11-year-old range. Next slide. And then this is just another way of looking at sort of the age breakdown. So our highest incidence right now is in that 18 to 49-year-old age range, but then 0 to 17 is right after that. And then when you again pull out under 22 years of age, you do see that the 5 to 11-year-olds are starting to be the highest and the increasing. So it's really a perfect time that we now have this opportunity to protect our younger children, our 5 to 11-year-olds across the country, but we're seeing again an increase in cases here in California. Next slide. So how does that translate, or wanted to kind of show everyone what we're looking at the state level as far as hospital capacity, because again, I think as we learn and have more opportunities, I think, certainly a theme today and in general for all of us is prevent every case, but what about serious infection and hospitalization? So this is sort of a nice breakdown, and let me walk you through this a bit. The lower right-hand corner is our statewide data for California. And what you see in that top linear line is our hospital census over time throughout this pandemic. So the first big peak there is actually when we had our winter surge. And so we tried to kind of calculate and look at, what we're calling 100% as sort of a baseline is the two lowest points we've seen last October when we had slowly reopened, but before the big winter surge. And then we had an even lower number of cases during post-vaccination and during our summer nadir. But of course, more non-COVID cases are filling our hospitals per our norms. So we tried to look at, again, the lowest levels of our hospitalizations and call that sort of a baseline at our lowest levels of COVID in California. And then these dashed lines right above there are at 110% or 120% of that baseline. So in California statewide, again, you can see our winter surge really put us above kind of, very close, and certain hospitals were really concerned that they were going to get to crisis standards of care. Thankfully, we were able to support hospitals enough to not get there. But you can see here with the Delta surge that it did get to over 10% as well. And it started to decline, but now it's actually at about 10% above that baseline again. So our hospitalizations overall, as far as total census, and then how does that map with the percent in the hospitals that are COVID positive? So the lower dashed line, still looking at that California statewide square, is about 20%. So if you look at the winter surge there, we got way over 20% of our hospitals were filled with COVID patients. And then we stayed just under that during the Delta surge, but again, you can see it starting to come up again. But then if you look at the regional variation, many of you know, especially those of you in Southern California was hit the hardest in the winter, and that, again, those peaks there, both COVID patients and which then bumped the overall census, were way above 20% of their baseline. And during this Delta surge did not get quite to the same level. But you can see here there are certainly some other areas, specifically pointing out San Joaquin Valley and our rural northern areas that are really getting and are at about 20% of what we're calling our baseline. So watching that really closely, wondering, we haven't seen a lot of flu activity yet, but very concerned again about other respiratory viruses that are circulating. We are seeing more RSV. So watching this very, very closely. Greater Sacramento is another area, as you can see, that there seems to be an increase in hospitalized cases a little bit there, and it's still, and again, at 10% or so above a baseline. So very concerned. And as all of you on the front lines know, we just have a cadre of very tired, very fatigued healthcare workers. So really wanting to be very cautious of this as we hit the indoor sort of winter months and the colder weather, and worried about more indoors and more gathering. Next slide. So shifting back again and then amongst those, how are pediatric hospitalizations looking? So the upper curve is, again, overall hospitalizations, and thankfully the orange line in that upper curve is pediatric. So it's, barely visible. It's really maintained in California, including during our Delta surge, less than 2% or so of our hospitalizations have been pediatric. And then the pullout here in the bottom right-hand corner is sort of the trends we've seen in pediatric hospitalizations. And again, you're seeing that they had started to decline, but are leveling out. They're not quite as low as they were during the summer, but they didn't get higher than that winter surge, which you saw from some of that national data that Dr. Shane showed happened in other states. Next slide. And then again, California-specific data about MIS-C, as Dr. Shane mentioned, typically the trends are a few weeks after the actual infection. So our peaks of cases and case reports typically do follow by several weeks, as you see here. We've had almost 700 cases of MIS-C here in California. About, let's see, 6 of those were deaths, and typically in general, about half of the MIS-C cases are in the intensive care unit. And we're definitely seeing, just along the themes that both other speakers mentioned of equity, we've noted that almost 60% of these cases have been Latino, and 43% of them have been in our least healthy places index quartile. So a lot of inequity here, along with our overall cases and hospitalizations burden. So really, and again, half of these kids were actually previously healthy and often had very mild or even sometimes asymptomatic primary infection, and then had this more serious complication. So again, this is what we want to prevent. The median age in California is 8. So again, this is the right age range now that we're hopefully going to get kids vaccinated and help protect them from this really serious outcome. Next slide. And then I also wanted to, there was an ACIP version similar to this at the ACIP meetings, and we've been pulling out our California data. I think, again, Dr. Lee mentioned comparing this to adults, and yes, it is true that kids do not have as serious hospitalization rates, et cetera, as adults. But if we compare COVID-19 to other vaccine preventable diseases, this is sort of our California burden. And you can see we've had 38 deaths in California to date. And this, one of our worst or more severe seasons was 2019-20, and 22 pediatric deaths. So some people are saying, oh, is it really that much worse than flu? And certainly as far as mortality, it is worse than flu. So, and again, just showing the burden of disease that we have for other vaccine preventable diseases as we think about all the benefits and risks of this vaccine compared to other vaccine preventable diseases in children. Next slide. And then just shifting gears for a moment, I just wanted to highlight one change we did just update, and it's updated on our website in our K-12 guidance. As you all know, we are learning more and more about antigen testing and having more availability of point of care testing. And so with more and more data we've accumulated, we're feeling, and especially with Delta, which again has a much higher viral load, much more confidence in antigen testing. So we looked actually specifically in our school-based cohorts at over 22,000 samples and found that our negative predictive value was 97.5%, and our positive predictive value of antigen testing was 92.6%. So with that data behind us, and also just hearing about a lot of the logistical and operational challenges that schools are having, and again, with some principle of having our best balance of safe and successful schools, so minimizing transmission, but also keeping kids in seats as much as possible, we have updated our testing guidance, and this is true for other non-healthcare settings as well, to say that an antigen test does not necessarily have to be confirmed. Certainly if people want that extra check, or if there's concern that there's someone asymptomatic who has positive symptoms and you want to confirm if that's a false positive. But I just told you that our negative and positive predictive values are quite good in these settings. So that is a new update I just wanted to highlight for clinicians to know about as well. Next slide. And then just some other quick highlights about booster doses. You already heard a lot of great information from Dr. Lee about this. This is California's version of trying to, and to something that Dr. Lee alluded to, we've wanted to simplify the messaging a bit more. So this is really all-encompassing. It doesn't quite tease out the subtleties of should or may, but from a public health perspective, really trying to make sure people know, at least know who is eligible, and wanting to get more uptake. We were really worried early on with our projections that we might be stretching our vaccine capacity, but in fact, we have not yet. But we have given boosters to at least 3.4 million people here in California, and about 32% of the 65 and over age group have been boosted. But we really want to see that number higher. Again, as you saw in my age proportion slide, and we're hearing anecdotal reports as well in some of our nursing homes and other places of fully vaccinated people who are vaccinated in January or February, that we really want to get boosted for that optimal protection. So we're really trying to get the word out to make sure that people who are eligible get boosted, especially before these winter holidays. Next slide. And then as far as 5 to 11-year-old vaccination outreach, again, you heard a lot more about the background on vaccine approvals, et cetera. We have about 3.5 million 5 to 11-year-olds in California, and they comprise about 9% of our population. So as far as improving our overall vaccine coverage, that will really help. We're at about 74% of our 12 and over are fully vaccinated across California, but only 58% of our 12 to 15-year-olds and 65% of our 16 to 17-year-olds. So, and that took us, you know, we know that our teens, the 12 to 15-year-olds, were eligible in around May, I believe. So it's taken us 6 months to get to those levels, and, you know, we're continuing to move that dial. But I am pleased to say as well that we have administered almost 74,000 doses in 5 to 11-year-olds already in just the last few days. And our initial allocations of a little bit over 1 million doses have already been arrived in California. So the vaccines are here. So really hope that all of you continue to encourage your patients and families and others that you are working with to get their kids vaccinated. This is some other key points just around what we're doing on the public health side as far as trying to do outreach. We have a big schools campaign. We are working on prioritizing with our Safe Schools team, especially a priority number of schools and our least healthy places index quartile across the state, and our local health departments and schools directly are doing a lot of great schools vaccine outreach. But we also know all of you as providers, again, are who parents want to have those conversations with to really talk through these benefits versus risks. So lots of great efforts going on that, and always looking forward to more feedback and support to get the word out. Next slide. And I think Grace already gave one plug, but I just am really loving how easy this VSafe, I was going to pull it up on your phone, is. And I'm getting my reminders after I got my booster, after my initial J&J. And I think it's a great way, again, that we can proactively get people to add to the data reports about vaccine safety. So just a quick plug for that. And with that, I will close so we can move to the panel. Thank you all very much.
Thank you so much, Dr. Pon. And I'm going to now invite Dr. Shane and Dr. Lee back on. We do have robust questions today, many of which are about some of the specifics of questions people are getting in their offices and having around their own family and community. So let me just start with a few booster questions, and you can kind of jump in and answer as you'd like. But a lot of people are wondering, what does booster really mean in this context? So we're used to boosters, you know, you need to get your tetanus every 5 years or whatever that is. And it sort of feels like it's a regular schedule. Other vaccines, you need a booster at one age, and then it's sort of felt to be pretty good for the rest of your life. Do we have any sense, given the mechanisms of immunity here, of whether this 6-month booster is going to become every 6-month boosters, or whether this is the last of this sort of version of the vaccines? Any guesses there?
I'll just comment on maybe the booster definition. This has been a challenge in part because, of course, we have additional doses for immunocompromised patients, and you know, booster doses. Like how to understand that, I think, has been a challenge. So the way I think about it is, what do we need to generate an immune response? And we think about that differently for immunocompromised patients compared to immunocompetent patients. So it's, you know, for example, for an mRNA series 2 or 3 doses, the booster is actually to help restore or refill your own immune response to the initial response that you had. I think you asked a really good question, which is, does this seem like an indefinite sort of plan going forward that we are going to have to need this? I do not think so right now, based on the information that we have, although I will be curious to see what Dr. Shane and Dr. Pound think, because I do think that we don't know what variants are going to come forward. We also know that we don't quite have a full understanding of the immune response. In particular, I'm interested in the J&J or the Janssen vaccine, which seems to create an immune response and sustain it over time. And perhaps, provides a different set of immune responses to COVID-19 than the mRNA vaccines. So I don't think that neutralizing antibody is the only answer. It is clearly the answer we have been anchoring on for the last few months. And I think that as we learn more over time, we'll have a better answer to that. I think the other question that keeps coming up is, should it always have been a 3-dose series instead of a 2-dose? I think regardless of the answer to that, I think the main thing is, are we maintaining protection?
Yeah, that's helpful. And maybe Andy or Erica, if you have anything to add, the other question is sort of, some people wonder, is this going to be something where as we get new variants, we may have to have a new vaccine? And my very unsophisticated understanding is that's what happens with flu. So we get a new yearly flu vaccine because the virus is so different, and we haven't had to do that in COVID yet. So this is sort of a different scenario. So do we have any anticipation of whether we're going to need that as well? And are companies already making vaccines that are specific towards, for example, the Delta variant?
So I think if I've learned anything during this pandemic, it's not to predict. But I think that, you bring up some really interesting points, and I think that it helps people to understand what's coming in the future. I think I just wanted to emphasize what Dr. Lee said. We don't really know what good correlates of protection are. And I think we're seeing that even more in children with such differential responses, both to vaccine and also to disease. And so I think we're understanding as we go, and we're learning as we go. And I think that's something that I really try to emphasize with families and parents, is that we're learning as we go, and we need your help in helping us and getting people vaccinated, and then we'll understand. I think it's really clear that the more people we get vaccinated, the better we will be. And we'll just have to see how things go. I think ideally it would be amazing if we could have a combined flu and COVID vaccine. I think that's everyone's dream, and perhaps even administered in a way that's not an injection. But I think I said I wouldn't predict, but I'm allowed to dream. So I think we just have to go with it. And this is uncharted territory, and so I think just explaining to families that it's uncharted, but we do have a lot of information. And as Dr. Lee mentioned, we've given millions and millions of doses, so we have a lot of information, and we can apply that to as we go.
Yeah, I think the only thing I would add to my colleagues is, and I absolutely agree with it, if there's one thing I've learned, it's not to predict, which is a common question, right? Like everyone wants to know, and we want to know too, but I think, and communicating uncertainty was a theme one of you brought up, and I think that is our biggest challenge. But I think what I wanted to point out is, and some of you alluded to this, but we have some vaccines that are a 2-dose series, some that are a 3-dose series, and that are a full series, 2, 4, 6 months, and then a booster at 12 to 15 and 4 to 5-year-old. And then we learned with Tdap and MMR, years later that we needed boosters. So on one hand, yeah, the future's unknown, and we are learning so much so quickly about this virus, and so grateful for all the kind of collaboration and technology and data collection that's happening to really inform us as quickly as we can learn. But I think it is unknown, and I think, but there are a lot of other precedents, and I bring that up mostly for vaccine confidence, because some people have mentioned, well, oh, does this mean it's not even worth it to get a vaccine at all? Or, I just want to make sure people think about, again, precedents. Like, we have a lot of other vaccines like this that are several doses, and that took us, years to really understand when immunity waned. So I think more to come, but we're learning much faster than we ever have, and a lot of great work going on there.
Great. I have the mean job of asking for predictions every time we do the series, as Dr. Pong knows, so I'll continue to do that. And thanks for giving your, they're predictions based on, some greater knowledge that many of us have, and so we're really grateful for that. Everybody wants to know around boosters, and I wonder if you have any comments on this, about whether I should get the same vaccine that I got before or mix. And I know there's been a lot in the press sort of giving recommendations about that. And of course, it's up to individual choice, but there are a lot of questions about that from our audience today. So wondering if someone wants to comment on that.
I can try. So, I think the other comment I'll make sort of following just this last set of questions was that we struggle because from an implementation standpoint, simplicity is much easier. And so it's easier just to give like a simple and straightforward answer. So I'm going to give both the simple and straightforward answer and then the answer if you come into my office and I get to have some time with you and talk with you about your own individual situation. So I think the short answer is, if you are at risk for severe disease or circumstances where you're at higher risk for infection, I believe that any of the boosters are going to be effective in terms of restoring your immune response and optimizing your protection. So I would say, again, thinking about who you are in those circumstances. But I do try and give people an opportunity to think about choice, about what, they value and what the potential side effects might be. And so, if I have a young male who really feels like they need a booster for whatever reason, I might say, you have options, and one option might be a J&J vaccine, for example. And similarly, if I have a woman who's in her 30s or 40s and got a J&J before, what should she get? I again say, like, you have an option, just knowing that like there's risks here and there's risks there, and it may depend on gender and age. But I don't try and make that the focal point. I really try and make the point, what is the benefit to you? And then just try and mitigate whatever risks you can to yourself. And then again, it's some of this is also just what is accessible and, how important is timeliness. So I try not to give any hard and fast rules, but if I have the opportunity, I try and understand the individual situation.
That's really helpful. And I think all of us have really struggled with that desire to keep things simple for implementation. And then, where is that place where we can sit down and have the more complex conversation, really approaching individual values? Grace, I'm really appreciative that you brought up those issues. Maybe we can just move to thinking about children and children's vaccines. I know I hear things about some families who are choosing to wait until there's more data, more information. And I know along this process, I feel like we have more data by far on this vaccine, than we ever have in the history of time on any other vaccine. And so, I try to communicate that in the way I can. But I also really try to emphasize what are the benefits to your children that are the non-clinical ones, because people don't feel that clinical urgency in the same way. And I wonder about some of the ways that we may begin as a public health rule to off-ramp some of the restrictions that have happened in children's lives, and that of course particularly happens in schools. So Eric, I know this is also kind of controversy. I always dip you in the stream of controversy, but is there a conversation about how do we start to change those rules that restrict children's ability to be children in school, whether it's masks or groups of people and how many can be together, et cetera, once they're vaccinated, the 5 to 11s?
Sure. I mean, I think, again, a few key points. One is that vaccines are the way out of this pandemic, right? Like, we really know that we need to get more and more people vaccinated and better coverage. So I think as we improve our vaccination coverage, as we increase our immunity collectively, we are going to decrease case rates and decrease morbidity and mortality, right? So those are all things we're constantly looking at. And I showed, people sort of where we are in hospitalizations too, which we're in kind of a very concerning moment still, even though, and we're again plateauing at a much higher level than we have in our last 2 plateaus. So we are constantly thinking about those things. But to the other thing we just all talked about, we have learned our lesson about trying to predict things. And so I think because, and again, I recognize that is really challenging, but I do, I think as things get better, we will peel away. And we've talked a lot, right, in public health and elsewhere about layers of mitigation, right? And we absolutely want to peel away as we can, but I think we want to see signs that we can. And I think, and we know, I mean, at a minimum, right, if your kid gets vaccinated today, it's still going to take you 5 weeks, right, to be fully vaccinated, and then you're at the holidays. So we wanted to get through the winter months. That's what our statement said about masking, and that's sort of where we are. We're going to continue to reassess, continue to watch all these indicators, and absolutely, as we get, you know, to a new place, we want to be able to peel away different measures as things get better. But I think tying our to any specific measure has been, you know, and trying to predict what's going to be happening at a given point or a given case rate or a given, you know, I think it was very interesting after the summer reopening in June 15th and where we were thinking about when we, you know, when we would be worried. And while we were thinking about it, Delta just surpassed all our thresholds. So, I mean, that is our lesson learned, and we are just continuing to assess all of these things.
Yeah, I'll also add, just from a pediatric infectious disease perspective, masking has had benefits on the transmission of other respiratory viruses that has been quite impressive. And I think along with masking, hand hygiene and other mitigation efforts, and hopefully hand hygiene will never go away, and this is a reminder as well. I think that some things that masks do offer that level of protection that allow children to do things together in groups and to be together at least until all of them are vaccinated. And so the challenging situation, I think, is when we don't have 100% vaccination or above some level, because that also presents an opportunity for transmission. I'll also say that I think, you know, children respond very well, most children, to consistency. And so situations where we say, okay, you don't have to mask today, but then if, you know, we had another surge, they would then have to reinitiate masking. So I think that that also is something that we struggle with. We obviously, nobody likes the masks, but I think that thinking about if we loosen up and then have to go back, how does that work? So we really want to make sure that we're at a good level. But you know, perhaps masking is the last thing to go, but there are other things that we can do in the interim that help children go back and be children.
Yeah, my 11-year-old daughter said to me, "Are they going to allow us to take our masks off at school?" And I said, "I don't know." She said, "You know, I think I'll keep mine on." So, you know, while many of the children hate masks in so many ways, a lot of them find it comforting. And in fact, my kids remember their masks much more than I do, which they shouldn't admit in public, but it's really become a part of their life. And I don't think it's as onerous as many of us might think it is. So speaking of kids, and as we try to roll this out, I know that there are some, so again, like, you know, I'm going to wait till it's been around longer, other specific things that parents have worries about that we anticipate that we might be able to develop kind of talking points for. And so one of those things that we've heard is concerns about reproductive issues, changes in puberty and ability to get pregnant in girls. And, you know, do any of you have a specific talking point about how to say to a family who has those concerns, you know, it's really not something you need to be worried about?
I think that's probably the one of the most challenging ones for me. But what I will say is that, you know, so sometimes when I respond, I say this seriously, during the clinical trials, they really tried to enroll people who are not going to get pregnant. And despite being in the clinical trials, people got pregnant. So I don't think that there's any, you know, clearly, even with the intention of birth control, it didn't work. And there were no differences insofar that we know of in terms of the outcomes of those patients. And we are continuing to monitor, for example, the safety and use of vaccines in pregnant women. And there's a pregnancy version of VSafe where pregnant women can actually share that information. And actually, it has been incredibly helpful to have that information in our pregnant women and having them share that directly. In addition, there are additional studies focused on the pregnant population, for example, in the Vaccine Safety Data Link that again have been incredibly reassuring in terms of pregnancy and birth outcomes. I think that in terms of fertility, I look to the experts, of which I'm not one of those experts, but there are statements from national organizations and societies that focus in on fertility and reproductive health in particular, who really focus on the importance of vaccination as a protective measure, and recognizing also that not only do we need to focus again on the importance of ensuring that vaccines are safe, But remembering in the context of COVID-19 that we actually, there are many things where we don't understand the full impact of COVID-19 yet. And I truly believe that vaccines are a much safer way to develop an immunity rather than getting an infection themselves. So that's sort of how I try to address it. I realize I don't have as much data as I would like to have on it, but I do think that that will come over time.
I agree, and I also think I've had a lot of questions from parents of boys too about male fertility, and there've been a few small studies that have also demonstrated the same, that there is no impact, small and large studies demonstrating there's no impact on male fertility, and actually maybe even an increase in some who have been vaccinated. So I think that you know, that's really an important point as well. And I think also very challenging, you know, as others have mentioned, it's a risk and a benefit. And unfortunately, we have taken care of a number of infants whose mothers and fathers have had acute COVID, and unfortunately, several have not lived to survive, have not survived. And so that's very challenging as well. And so I think thinking about those risks and benefits is really important as well.
And the last thing I would add, although I definitely look to my vaccine expert colleagues on this one, but you know, this is a common sort of myth and or concern for all kinds of vaccines. And to my knowledge, there is no other vaccine in history that has had any impact on fertility per se or hormonal. And I can't think of a physiological reason why that would be. I absolutely, you know, we want to continue to follow this data, and certainly there's really robust data about pregnancy. But that is my understanding as far as, you know, there have again been prior concerns about this, and have not seen any data about impact on fertility or hormones, you know, sort of reproductive hormones for that matter. But again, I look to my colleagues if you know of anything that I'm not aware of.
That's all really helpful. I want to sort of change the subject for a minute. And Dr. Lee, it was really helpful to see the evidence to recommendations framework that you shared and all the things that you think about as a committee and all of the people who are on that committee. And throughout this whole pandemic, you know, I, as a pediatrician and a mom, have really watched the way that our country, compared to other countries, has, in my mind, sort of been slow to acknowledge the impact on children. And much of the impact that Dr. Shane, you acknowledged so beautifully, is not necessarily purely clinical. And so when you think about benefit and risk balance, someone in the room has to say that the risk to children is not just how many are hospitalized and what the disease is. And I hope that this experience maybe has brought that voice a little bit to the forefront in these big decision-making bodies. But I think we've been slow to really be mindful of our children and their future, which means the future of our country. In many ways, I wonder how and if you think that this will change the way we think about, and you again alluded to this, engaging kids in clinical trials earlier at the onset of starting to study any vaccine or drug or anything else. And do you think that's going to change because of our experience with this pandemic? And if not, you know, how do we sort of get that word out? Where do we advocate?
I certainly think that advocacy efforts are going to be critical. I mean, I would say prior to this pandemic, so first of all, do I wish the kids went forward with the trial sooner? Absolutely, because we knew that they were going to be impacted directly by the pandemic, not only by infection, but by the fact that we had to close communities and schools and all of their activities, and that really impacted, mental health, social, emotional sort of wellness. And so I do think that we don't do enough to actually study it, demonstrate it, and demonstrate the full impact. So I actually feel like it's not just vaccines, it's all of pediatric health, because I really see, we compare like the number of hospitalizations, and I'm like, that's not as relevant as the impact it has on one's educational trajectory, because these small differences in childhood may not feel like a big deal to an adult, but 5 months of loss of learning can actually have a huge impact on the outcome of that child. And we know that there are disparities to begin with. So let me just say that I'm a huge advocate in thinking about the whole child. Health is just one aspect of the outcome of that child. And then I very much that life course approach where, I think that small things that happen to children now can have huge impacts in later life in ways that we can't even understand. I think that we are underfunded in our knowledge and have underinvested in what we need to do to really understand the full impact of the pandemic on children overall. I do think absolutely we need earlier trials with regard to vaccines and other interventions to become available. So for example, we're talking about a new oral antiviral therapies that might become available soon, but it's clear that won't be available in children, and we still are going to have children that all of us need to take care of in the hospital that would benefit from that therapy. So I think advocacy is the answer here. I certainly think that even, I would say, understanding risk factors for who's at risk for severe disease, the data is so predominantly adult focused because that's where the numbers are. And we haven't really paid as much attention as I would have liked until, sort of the pediatric decision becomes imminent. And I still think that we need more data. So I would very much be in full support of advocacy to not only continue the efforts in the arena around clinical trials and inclusion, not just of pediatric populations, but of pregnant women, of diverse populations. And again, like our trials, until we had this crystal laser focus on the diversity of these trials, I had not previous to this seen diverse populations enrolled in clinical trials. So I do think we need to draw attention to it. I hope that ACIP can be one voice in this, but it's clearly going to take all of us to be able to advocate for the inclusion of children in clinical trials, in better studies, and understanding long-term outcomes. And I'll just throw in, while we're at it, long COVID, because I think, again, there's an assumption that it doesn't impact kids as much. I think we don't have any understanding of how it's actually impacting kids yet, and we need to continue to invest in that.
Yeah, thank you. And Dr. Shane, do you have any sense of sort of where we advocate, who we talk to, how's the best way to do this given your FDA experience or other experiences?
So great, and I couldn't have said it better than Dr. Lee. It was just so beautifully said, and I think that we have to start at all angles. It's not just one location. There are some regulatory statutes that are in place that are one place to start. And I think obviously there is awareness, and I think we just have to keep our voices loud, keep our voices together, advocate in the local level. I also think that some of our most passionate advocates are our parents, and they have been wonderful in terms of wanting to have their children vaccinated, wanting to engage their children in clinical trials. I don't think we have ever had to turn down hundreds of families who volunteered to be in our clinical trials before, as we did now. And so I think that there really is an awareness. So working at all levels, families, and working with children too. Our children are very powerful and have a good understanding, and older adolescents can be a wonderful advocate. Their families, their parents, their physicians, local and public health organizations, ACIP, CDC, FDA, everywhere we can, we should advocate for children.
Great, thank you. We are almost done. I want to ask two other super quick kind of lightning questions. College students, should they get boosters because they're in sort of a pretty high risk environment?
Dr. Polland.
I mean, I think, I think that is certainly a high risk for exposure. And I think that was the other part about the nuanced messaging, high risk for severe outcomes versus exposure. But as far as, and I think, and Grace has brought this point up today and previously, if we're talking about decreasing infection and transmission, I think yes, absolutely. So, and certainly could be considered a high risk setting for exposure. So.
Thank you. And finally, see who jumps on this one. An immunocompromised patient, I don't have any details about the type of immunocompromise, who've had 2 vaccines and a booster, how careful do they still need to be?
No, Dr. Yes.
I'll try. I mean, I think, if you've had your 3rd dose as an immunocompromised patient, you've had at least what we understand now, the optimal protection from vaccination. But we know that vaccination is only one part of protection. And so I think it depends on what part of the country you're in, what kind of activities you do, what your level of immunosuppression is. And, you know, we have a lot of our immunocompromised patients who would wear masks before COVID, just during the respiratory viral season. And so I think even though we are very focused on COVID, these other mitigation methods like masking, hand hygiene, making good choices about travel and events and going out to restaurants, I think it's, once again, it comes down to the individual.
Well, that's a wonderful way to end. Thank you so much, Drs. Pan and Lee and Shane, for being here with us today, for presenting your content, and mostly for the work that you've done over these many months, and I'm sure we'll continue to do. Thank you to everyone who's listening in for taking the time to view our webinar. I'll just preview that our next session will be Tuesday, December the 7th. This is slightly earlier than our usual second Tuesday, so please be sure to mark your calendars. And the information is available at www.covidroundsca.org. And just remember to complete your survey and attest to your attendance to get CME. Have a wonderful day, everyone, and get your kids vaccinated.
Bye. Thanks, everyone.